Welcome to Eye Contact. I'm Aidan Hanratty, and today I'm talking to Dr. Basak Bostanci about cataract surgery in trauma patients. Welcome, Dr. Bostanci. Perhaps you could start by reviewing your assessment of a new patient arriving in the clinic or emergency department.
Sure. So first of all, we mustn't forget that these patients are trauma cases. So even though they have cataracts or ocular trauma, they can have some accompanying systemic status as well. So we mustn't forget to evaluate the airway, breathing, circulation of the patients, which are the ABCs of emergency care. This is usually done by the emergency care department, but as an ophthalmologist, we must keep in mind that if a patient has an ocular trauma, he can also have an accompanying head trauma, like an intracranial bleeding. So we must evaluate this first. Later, we must take a quick history of the patient regarding the impact of the trauma, whether it was a penetrating injury or a blunt trauma, whether there was a foreign body involvement, and also try to learn something about the tetanus immunization of the patient, and also try to learn about the systemic condition, and as well as the ocular history of the patient. Later, we try to use some guidelines to evaluate the ocular health. There are some guidelines showing that the visual acuity, the impact of the trauma, as well as the pupil reflexes, are prognostic factors for the final health of the eye. And at this point, I should emphasize that sometimes an eye can be brutally affected, but there might be some minor changes in the other eye. And if these changes are so subtle, we can miss these changes, and eventually there can be some devastating complications. So we must make sure that both eyes should be checked.
Of course. Because of the special nature of these cases, do you need to carry out separate physiological assessments, especially in severe trauma cases?
Yeah, well, like every other examination, our exam starts with inspection. So we try to understand if there's any muscle entrapment, the motility of the eye, and we evaluate the general anatomy of the eye. Of course, we use special tests like a Zeidel test to see whether there's a penetrating injury under the biomicroscope. And in each case, we should have an algorithm to evaluate both eyes, because in order to not to miss anything. So what I do is, starting from the outside of the eye, starting from the eyelids, I check each and every compartment, because usually cases with cataracts, traumatic cataracts, can have some accompanying surrounding tissue damages, like the angle structures or like the pupil, the zonules or the posterior capsule. So we must evaluate each and every single compartment. I use some imaging techniques for trauma cases. Usually I start by using some plain X-rays. X-rays are great ways to show if there's a metallic foreign body involvement. But if we are to see if there's any bony structure involvement, computerized tomographies are much better ways to evaluate the eye. And they can be used in the suspicion of a metallic foreign body, which MRIs are contraindicated. We must also add MRIs are contraindicated in patients with heart pills. And one key point to emphasize is using an ultrasound. A B-scan ultrasound is very crucial for seeing the back of the eye, but in the suspicion of a globe rupture, applying a pressure over the eye is dangerous, because you can always extrude the eye contacts, so we must be careful.
Of course. What are the typical traits of a traumatic cataract, or are there any typical traits?
Well, according to the textbooks, there are some special traits. A rosette or stellate type cataract with a Vossius sign, which is the imprinting of the iris over the anterior capsule, can be seen. But depending on the impact of the trauma and the mechanism of the trauma and the time interval after the trauma, a traumatic cataract can come in any shape.
Right. And how does your approach differ between older and younger patients?
Well, In the pediatric population, traumatic cataracts are a big problem, really. One of the most difficult things about evaluating pediatric cases is just putting the diagnosis. Because if the patient has a penetrating trauma, it is so gross that the patient is usually brought immediately by the family. But if there's a subtle trauma, if the cataract develops in time, it can't be missed by the doctor and by the family. So the pediatricians and the families should be warned that if the kid has a chronic red eye and some visual disturbances, and if there's a history of an eye trauma, congenital cataracts, the possibility of a cataract must be kept in mind because it develops over time and the kids might be unaware of it. So in pediatric cases, inflammation is more usually, and if the kid is younger than 2 years of age, usually a pars plana route is chosen, and when taking the lens out, we also do a vitrectomy. Right. And under the age of 2, we don't put intraocular lenses, so we do the correction with for the aphakia with contact lenses. But amblyopia treatment is a key thing here. So what we are afraid most is amblyopia in certain ages. So we usually see them more often compared to our regular trauma patients, and we try to do the aphakia treatment in a very well-organized manner.
Right. Coming back to IOLs, when do you insert an IOL, and what do you use for IOL power calculation in these cases?
Yeah, so in a cornea, when there's laceration, it is really, really hard to get an accurate measurement. So if you have a laceration on the cornea, if you think the corneal contour is going to change over time, maybe leaving the IOL placement as a secondary procedure is a wiser idea. It also applies to eyes with great inflammation or if the visualization is really poor. You can always, put an IOL as a secondary procedure. But if you are very decisive about putting an IOL in such a cornea, you can use the other eye as a reference or use an average number like a 44 diopters for biometric measurements. Also, the type of the IOL is important here. So it is always wise to have a 3-piece IOL under your hands because they are easy to be put in the sulcus, or you can secure them to the sclera or use them as a glued IOL or as a Yamana technique. If you have a good bag, you can always use a 1-piece IOL, but in this case, you have to make sure that you're using an acrylic lens because these cases might have a retinal surgery in the future or might have some inflammation in the future. So acrylic lenses are recommended compared to silicone lenses. And one more thing to add is in really young patients and in an already compromised cornea, it is not recommended to use an anterior chamber lens.
Right. Well, thank you very much for joining us today.
Thank you so much.
For more information, please visit us at eurotimes.org.